Well, hello and welcome to the 27th Degree with Chris and Nancy. Today, joining us is Dr. Gupta to discuss sleep apnea. But before we begin our conversation, I want to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are greatly appreciated. So let's start by just learning a little bit about yourself and about how you got into sleep apnea. So tell us a little bit about yourself, Dr. Gupta.
So basically, as far as education goes, my medical school was in India. Then I came to US for further training, did fellowship in pulmonary critical care medicine.
Okay.
And during that, there were a few patients with sleep disorders I got to see, and I realized, oh, that's fun. And I've come this far in medical training, and now is the first time I'm hearing about a sleep disorder.
Right, because we didn't learn a lot about that in medical school.
So there was nothing about that in medical school.
No,
even in internal medicine residency, I must have not paid attention, I guess.
You're right. I mean, I went through internal medicine training, and even doing my pulmonary, training during my internal medicine training, we never were taught about sleep apnea.
So, once I finished pulmonary critical care fellowship, there was this 1-year sleep fellowship available. So that was brand new at that time. Just before the program, I was telling Nancy how there were 8 programs in the country at that time offering a sleep medicine fellowship in 1998, and 1 fellow per program.
Okay, so not a lot.
Out of it, 1 was not a paid position.
Okay.
I had to support my family.
Wow.
So I was fortunate enough to be able to get into the Mayo Clinic sleep medicine program at Rochester. One of the, I was so happy. But, that's a separate conversation topic. Great place to learn, great place to work, minus the snow.
Right.
And then after I finished that training, then the first job was at Roger Williams Hospital, pulmonary critical care and sleep medicine. But really my mandate was I was brought in because of my sleep medicine qualification to run the sleep lab.
That's nice. Great. So you did 4 years of you did your internal medicine training, which is 3 years. 3 years. Then you did pulmonary critical care, which was another 3 years.
Another 3 years.
And then 1 year
of sleep medicine fellowship.
It's a lot of training.
Yeah.
And sleep medicine is interesting because you can approach it also as a neurologist, right? Neurologists can become sleep specialists. Yes. Pulmonologists become sleep specialists. I'm not sure if there's any other
at that
field
time,
that does, but
there were 3 main pathways, and that was through psychiatry.
Psychiatry.
The sleep medicine field was started by psychiatrists.
Really?
Wow.
Pulmonologists took over later,
okay.
but it was started by psychiatrists first, then came neurologists, last were pulmonologists, and now they're sort of...
What's the link with psychiatry?
Well, I think it must have been the research part, but if you think culturally, when we talk about sleep and difficulty sleeping, you really talk about insomnia.
Yeah.
And sleep apnea was not an identified disorder long ago.
Okay.
So I think a lot of focus was learning about sleep, what happens during sleep, all those things that go wrong during sleep that psychiatrists have to do. I'm not a history buff, so I don't know exactly what those origins were.
That's fascinating, though. I never knew
that may be my best guess.
Neither did I. That's an interesting little tidbit.
But once we learned about sleep apnea, which is a breathing disorder, then we use this equipment which are kind of came out of the ICU ventilators.
Okay.
And still the way the settings are done, adjustments are done, if you have that background knowledge, it's easier. So,
of course,
by default, a breathing disorder came into the pulmonologist's realm, kind of, and the majority of sleep doctors are pulmonary doctors now.
Right.
However, there is neurology, psychiatry. Now, ENT specialists have become board certified in sleep medicine.
Interesting.
Okay.
So they practice the medical and surgical aspects of sleep medicine too. Then, as the demand for sleep medicine went up, it's more prevalent than all of the common disorders. So this must be the most prevalent disorder. So you do need a lot of sleep medicine providers. So now there is a pathway for, after you finish internal medicine training or family medicine training, you could do 1 year sleep medicine fellowship.
Oh, really?
Oh, that makes sense.
That's interesting.
Yeah.
What was it about it that got you excited about this field? I'm curious.
Because I knew nothing about it.
Okay.
Perfect.
That was enough to get me sucked into it.
Of course.
It was something new.
Mm-hmm.
So that was fun. The curiosity aspect was the biggest one.
Okay. And
like I said, I didn't know nothing about it.
So maybe you could start by just telling our audience, talking to them about what sleep apnea is and why it's important. Why do we care about it? Why is it important to those who have it?
So the word apnea itself means stopping breathing.
Yeah.
It's happening in sleep. So that's sleep apnea. So translation, stopping breathing during sleep. Now, breathing is one of those basic functions of the body
kind of important,
so we kind of
we don't think about. We take it for granted. It happens automatically. It should be an effortless breath. We do spend energy, but a normal breath consumes very small amount of energy.
Right.
So it should not cause any distress. And if that vital function keeps getting interrupted during sleep, then it has multitude of effects on the body. The oxygen level goes down, the carbon dioxide level goes up. There's increased release of adrenaline that sort of gives you spikes of blood pressure. So the whole system gets deranged. There are frequent arousals, and the brain doesn't get the deep restorative sleep that's needed. So pretty much bad sleep affects all of your health.
So it's more than just making you grumpy. It's kind of deteriorating your body, it sounds like.
Yeah.
Well, lack of sleep's been associated now with dementia, the risk of dementia. We know it causes hypertension, sleep apnea, heart disease, quite a bit.
Diabetes. That we should pretty soon hear about cancer. Lack of sleep being a carcinogen, maybe.
So crazy. Like no one thought about this years ago, and all of a sudden, sleep has really come into the forefront.
I think that technology has made it possible.
That's very true.
To be able to study sleep, think 100 years ago, we didn't have the tools, and people had to work in the daytime as well.
So how do I know if I have sleep apnea? Unless so my husband might say, hey, you're snoring, knock it off, or whatever. How do you know if you actually have it? And
so snoring is often a red flag.
Okay.
Because we'll look at a picture and a video later to show that how the same narrowing of the throat initially produces snoring.
Okay.
That's one manifestation of a smaller airway.
Okay.
But the smaller airway will also reduce the size of breath, or a blocked airway will stop the breathing.
Sure.
So then it becomes sleep apnea.
Mm.
So both phenomena are due to the same process of the airway getting smaller. So that's why snoring and sleep apnea go hand in hand, but they're not it's not that if you're not snoring, you cannot have sleep apnea.
Mm-hmm.
Often with aging process, the snoring frequency goes down.
And not all snorers have sleep apnea either.
Not all snorers have sleep apnea.
But it's a risk.
Yes.
Okay.
So there is this progression from normal breathing, which should be noiseless, to snoring, to loud habitual snoring every night, where often at that point the size of the breath will be reduced, and that becomes sleep apnea.
Okay.
So say I sleep alone. How do I know if I have a problem or not? Like no one's waking me up and telling me to be quiet, putting a pillow over my head or something. You know?
That's the ultimate apnea when the pillow goes over the head.
That's actually the perfect treatment.
Oh my God. But like, what do you feel like if you're...
There are several other red flags. So what the patient feels, let's pull up a slide here.
Okay.
And so how a patient would know, or how doctors learn, or family members learn. Some of the symptoms, it's easier to understand by what causes those symptoms. So like we said, the real culprit is our throat getting smaller during sleep as the muscles relax. And that's the area behind the tongue and the palate.
Is that always due to like obesity? Like what else causes that narrowing?
Obesity is a major factor, but then the size of the jaw, everybody is born with a different shape and size.
So some people could be like in perfect shape, but they just will get sleep apnea.
Larger necks, short, thick neck.
Okay.
Some people have very small chin. We call it retrognathia or micrognathia.
Okay.
So different, for example, Asian Oriental races, they have more sleep apnea without being obese. Just that overall the size of the body is smaller.
Okay.
And then their craniofacial structure is such that the airway is smaller.
That makes sense.
So if you have smaller airway, that would produce the snoring sound. When you breathe through a smaller hole, it creates the vibrations, especially the palate and the uvula vibrates. That's what the snoring.
Okay.
That there are other structures that can vibrate. And then occasionally that reduction in breathing and reduction in the oxygen level is enough where you wake up consciously. I mean, all of the sleep apnea is reduced breathing, waking up your brain, but that is happening at a subconscious level. You're not aware of it. But occasionally you wake up. I snored myself awake. We call it the snort arousals, or gasp myself awake. Or sometimes patients will say, oh, I wake up startled. I don't know why.
Oh, all right. Because I was just going to ask you, like, I'll wake up like 2 or 3 times a night, but like I don't think I'm snoring.
Yeah. The snore is done with by the time you're consciously awake.
Right.
So the sound is over. But there are times when the sound can get a little prolonged so that you're consciously awake and you still hear that last part of the snore.
Yeah.
So then you're aware that the snore woke me up.
Okay.
But otherwise, you may just startle awake. Some patients sit up in bed feeling like they were choking, they cannot breathe.
Oh, okay.
And some people feel the consequence of that because with each such episode, there is a big rush of adrenaline.
Oh,
so
right.
Some people will say, I wake up with a panic attack. Or they just have pounding heartbeat.
Okay.
And, So a lot of those consequences of a pause in breathing, how the body responds to it, those are the things patients feel and report. So that's what the spouse is generally, half of the patients come to me because my spouse sent me over.
Yeah, that makes sense.
The snoring is disturbing them, or they're noticing the pauses in breathing and they're getting concerned. They're shaking the patient. Are you okay? Are you okay? Because they've not taken a breath for 30 seconds.
Dr. Gupta, so like, when is it a risk? Like, suppose someone snores a little bit. Like, when does it get to that point where, you really need to go get checked?
So there isn't 100% answer.
Okay.
But if the spouse has noticed pauses in breathing, that is a clear-cut risk.
Okay.
If somebody is waking themselves with that snore or a gasp, that does indicate that episode was a sleep apnea. Now, how often it happens during sleep that they're not aware of, that decides how bad it is.
Okay.
But the next category, what are the consequences of bad sleep? So this sleep apnea is producing fragmentation of sleep, causing repetitive arousals.
Okay.
That often results in feeling sleepy, tired,
Okay.
Lack of attention. Some people complain of memory problem.
Right.
Remember, cognitive dysfunction, or they may have, fallen asleep driving and come in after a driving accident.
Okay.
So various ways how bad sleep will manifest, but sleepiness and tiredness is kind of the most common complaint that bring patients to my office.
Okay.
And then you have other phenomena that happen within, like headaches in the morning, waking up with a headache.
Okay.
Most of those patients will be tired, so the headache may not be their primary complaint, but tiredness may be. Or some patients have really gone to neurologist after neurologist for headaches. And the sleep apnea could be a problem. Or nocturia, which means going excessively to urinate at night. And males often just attribute it to a prostate.
What's the link there? I don't understand how that ties back to sleep apnea.
I have kind of a layman's explanation. It's not the scientific explanation.
No, please, layman. That's the one I want.
It's like your kidneys are complaining.
Oh, okay. Okay.
And they're letting go of the water.
Okay.
Their job is to reabsorb all the water. But to do that job, they need the right circulation, the right oxygen level.
That makes perfect sense.
However, that's not as simple. The actual reason how this happens has to do with hormones, blood pressure changes.
I'm good with layman explanation. Thank you.
Yeah, so those patients might often see a urologist. Sexual dysfunction, loss of desire. Those patients may end up with urology or get their testosterone level checked and go on that trajectory. So there is a lot of this overlap of the symptoms of sleep apnea because it's affecting any organ in the body. And each organ is going to complain in its own language. So the heart may present with a sudden onset of arrhythmia like atrial fibrillation or a heart attack. Brain is going to complain by either being sleepy or attention deficit disorder or a seizure that was supposed to be once in 6 months becomes once a month, or have a stroke. We have all these labels for all these disorders. But for all these ailments to heal or restore, the body has to restore itself in sleep.
So this is really tricky because you can talk away all these symptoms. Oh, I have a lot on my mind. Or, I kind of tossed and turned. My dog was barking or something. Like everything, you could justify everything because the first thing that probably wouldn't pop in your mind might not be sleep apnea.
Right. So true. And then some of these you can look at and think you have other conditions too, like morning headaches, maybe I have a brain tumor or, night sweats. Maybe I have cancer. These are things that people
definitely
think about.
Patients would generally get a CAT scan before they get a sleep study.
Oh, yeah. Really?
Oh, yeah. Sure. Of course. If someone came into me with morning headaches, it's the first thing I would think about, really. I do a neurological exam and I'd probably say, well, these are new. They're occurring in the morning. Let's scan your brain, make sure you don't have a tumor. And I wouldn't even really think about sleep apnea until afterwards, but now I will.
How come men are more likely to get sleep apnea?
Yeah, it's just favoritism,
just the way it is.
Or sleep apnea favors men somehow. No,
all right.
It's hormonal.
Okay, is that why menopausal women too?
So estrogen and progesterone, the female hormones, stabilize breathing.
Okay.
Actually, the progesterone is often used as a respiratory stimulant in hospital situations. It's not that effective, but has been used. So these before menopause, these hormones do provide more stable breathing. Okay. So even with the obstruction to the airway, there's less chance the breathing will stop.
So the sedentary lifestyle, is that because people tend to be a little heavier with the sedentary lifestyle?
So weight, 2/3 of sleep apnea are either overweight or obese.
Okay.
But that also means that 1/3 of sleep apnea patients are not overweight.
Okay.
So we should by stereotyping the weight and sleep apnea, we kind of miss the non-obese patients. And it's not without cost, because then they get a label. They're still feeling tired or something. They're still having symptoms. They just get different label like depression or fibromyalgia or chronic fatigue syndrome or something. So because nobody thought about sleep apnea on them, because sleep apnea is only supposed to happen to overweight people.
Mm-hmm.
So, but obesity is the major risk factor. And the reason why we have the number of sleep apnea patients increasing worldwide has to do with increasing obesity worldwide.
But it's interesting that, as you mentioned, you don't have to be obese to have this condition. And I think a lot of people think it's only associated with obesity, which it's clearly not. So, key point.
We just talked about a whole lot of stuff. Is there like a key combination of symptoms that you're like, oh, classic?
Snoring and tired.
Okay.
And if not tired, the other words would be non-restorative sleep or don't feel refreshed in the morning.
Okay.
So I've done this other lecture for a primary care physician, and I said, well, if screening, how do you screen? You just ask the patient, are you satisfied with your sleep? Do you snore?
Mm-hmm.
If the answer to both those questions is no, then you're not missing too many patients.
Okay. Dr. Gupta, is there any research that you're aware of that talks about like people that work the night shift and are trying to sleep during the day, or like kind of against what the usual is? You know, like, or if you only sleep for a couple hours in the morning and then a couple hours at night, or is...
So that all shift workers suffer from bad sleep.
Okay.
Human body was just not made for night shift work.
Yeah.
We have internal clock that is always synchronized with the light.
Okay.
And we have endocrine system. Our hormones respond to light and day. So when we go out of sync with the night shift, that's the same. It's like a constant jet lag.
Right.
It's a persistent jet lag, and it has a serious consequence to health.
Okay. Mm. So now if I'm feeling these symptoms and I go in and say, hey, doc, blah, 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 and you're like, okay, sleep apnea. And then I get sent to you, Dr. Gupta, what are you doing with me?
We'll be doing a sleep study.
What does that mean?
So the way to diagnose sleep apnea, obviously we ask questions for the history, we examine the throat, and those are the red flags to decide, okay, this patient needs a sleep study.
Okay.
But truly, if the spouse has already diagnosed sleep apnea,
yes,
your job's easy.
Right.
At that point.
If the wife says he snores, he stops breathing in sleep, he falls asleep watching TV,
yeah,
the diagnosis is done. The sleep study is going to show sleep apnea.
Okay.
It's required for confirmation, but I'd be so surprised if it didn't show sleep.
Mm.
So it's like the probability goes up. And the type of sleep studies we do, there are two main types. The home sleep study.
Okay.
That patient takes the equipment home and sleeps with it.
Okay.
It is a limited recording. We call it cardiopulmonary recording or just respiratory recording.
Okay.
It's not a real sleep study. We don't know if the patient is awake or asleep.
But you still get use out of that?
It's at night. It's at night. So we assume that most of the recording is during sleep.
Okay.
And if we're able to record the snoring or see the changes in breathing, that gives us a good idea this must be sleep.
Okay.
The full sleep study done in the sleep center records a lot more parameters.
Yes, of course.
So before we go to that sleep study, this is basically what we look for on physical exam is how does a patient's throat look? So when we're trying to, and that is what a normal throat should look like.
Okay.
So that is the soft palate and uvula and the tongue. Tonsils are supposed to hide there. I have a separate picture just showing where the tonsils are supposed to be. All of these structures. So what is remaining in the middle is the breathing space.
Oh, okay. Yep.
So when we breathe, that air is going from the nose behind that palate. So it's coming from the top there behind that palate.
Okay.
And then going behind the tongue down into the lungs, right?
Yep.
So during sleep, now most of the sleep apnea patients fall in this category.
Of course.
Last 3 and 4.
Yep.
So they have a mismatch, either a smaller jaw or a bigger tongue, and often both.
Okay.
And then the only place the tongue goes is backwards.
Okay.
And then on top of that basic structure, now if somebody gains weight, that makes it worse.
Of course.
So
when you're looking at that class 4, I mean, how are they breathing at all?
Well, while they're awake, the muscles keep this. So there is still a passage behind this.
Okay.
Okay. So the tongue is coming all the way up here.
Yeah.
But the tongue is up towards the front.
Yep.
Okay. So it is up towards the front, and that passage is open, although it's maybe less than half of a normal size.
Okay.
So that's why alcohol must exacerbate this by
big time.
loosening the muscles in that area and increasing the obstruction.
Big time.
Yeah.
So during sleep, the tongue relaxes, the palate relaxes, and they drop. And that's what produces that obstruction to breathing. So that's why it's called obstructive sleep apnea. That's the most common variety.
Okay.
So that's kind of the anatomical background for this.
Yeah.
So when we're recording the patients in sleep study, we're recording their breathing through the nose and oxygen saturation. And we can see how the breathing is reduced, how the shape of the breathing changes, and how many times they stop breathing during sleep. And we count those episodes. And we have different types of episodes. The word apnea means complete cessation of breathing. The word hypopnea means reduced breathing. So we can add those up. And to standardize the number, we divide it by the number of hours of sleep or hours of recording.
Okay, that makes sense.
So that's called apnea-hypopnea index.
Okay.
Normal individual will have some irregularities in breathing, so that can get counted as pauses in breathing. So 2 or 3 could be normal.
Okay.
But cutoff for diagnosis of sleep apnea is 5.
Oh. Okay.
So when it is 5 or more per hour of sleep, then we call it obstructive sleep apnea.
Okay.
Or any kind of sleep apnea. If they are obstructive type of events, then we choose obstructive sleep apnea.
Okay.
And more than 30 events an hour, we call it severe sleep apnea.
Okay. Wow. That's a lot, 30 per hour.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So I flunk. I go to your sleep lab and I flunked. And I see you like the...
No, if I find you have sleep apnea, you passed.
Oh, okay. Well, I passed with flying colors then. What's the next step? I see some contraptions you have here.
So this is the CPAP machine. And basically, all of the treatments are trying to keep the airway open.
So you're going right to this. Because I see a lot of commercials for certain things like pillows or just, you don't.
No. So there is a difference between a doctor's treatment and a patient's self-treatment.
Okay.
If a doctor prescribes a treatment that is only 20% effective or 10% effective, I don't think the doctor will stand a chance of.
Right.
So doctors are not supposed to prescribe bad treatments or less effective treatments. That doesn't mean that they will never work. But that's not doctors' role.
So when we're talking like nose strips and mouth guards, that's...
So an occasional patient may benefit.
Okay.
Because really the problem, as you can see, problem is not in the nose.
Right.
The sleep apnea problem is in the throat. Now, the way the physics works, yes, if the nose is constricted or blocked in some way, the way the pressure changes happen, that would create kind of a negative pressure here and suck the upper airway close.
Yeah.
So opening the throat can opening the nose can stabilize the airway or the...
So that's the thought behind some of that stuff.
So a very few patients will improve with... They have to have a nose blockage to start with. If they have a normal nose, they're unlikely to respond to those.
Okay.
So already you've restricted. So all of the treatments directed towards the nose breathing, right off the back, have a very low success rate for sleep apnea because that was not the root cause anyway.
And with all those risks that...
Similarly, surgical treatments for directed at the nose are not going to fix sleep apnea in majority of the patients.
Okay.
So the best way I explain this to the patients is this is having a flat tire here every night, and you need pressure of air to inflate it.
Yep.
So the process of inflating this is no different than inflating a tire.
Okay.
You need a compressor that can pump air. So we got the blower machine here, and then we need a hose, and we need to make an airtight seal with a valve stem. So this nose or the mouth is the valve stem, and then we use a mask here.
So that's a little mask.
So I'm not trying to scare anybody here.
No, please. I like that.
But this is,
okay.
It's hard to wear this with the heart.
Sure. But we get the idea.
But this creates that airtight seal. So now the pressure of air will inflate the back of the throat.
So you don't need your mouth covered with this particular.
Now, if the mouth opens, I will lose the pressure.
Okay.
So there are patients who are unable to hold their mouth closed. So in that case, you have to use the mask that would cover the nose and mouth.
Okay.
And there are so many shapes and sizes. I just have three here, but there are so many shapes and sizes of masks. We have about 20 or 30 popular masks.
Okay.
And there are more than 100 out there.
Wow.
So there's a mask for everybody.
So, I've had patients go for sleep apnea studies. They've been found to have, severe sleep apnea, and they come home with a machine and they try it, and I just can't tolerate the mask, and then they give up. But they should go back because there's so many options, it seems.
So a lot of the intolerance to CPAP has different components. Now, for the real CPAP intolerant patient, there are some other treatment options. There are surgical treatments. There is oral appliances, mouthpieces that dentist makes. They are less effective compared to CPAP. However, they are good treatments because they have at least some impact, right? So compared to no treatment, oral appliance made by dentist is better. Okay. If somebody was compliant with CPAP, able to tolerate CPAP is going to produce the best response. Then you cannot compare it with the oral appliance.
Okay.
Same thing with surgery. Compared to no treatment, surgery will give you better outcome. Compared to CPAP, surgery is not going to be as good as CPAP.
So, Dr. Gupta, for those 2/3 of how is that phrased with the obesity as a risk factor? It's 2/3 of obese people.
I think it was 2/3 of patients with sleep apnea are obese.
Okay, yes. If they lose weight, do they tend to kind of solve the problem? Or it's just that's an individual call?
So the studies are...
I'm just asking because a lot of people are getting like gastric bypass and...
So this is a trap that a lot of people fall into.
Okay.
I will just work on the weight loss. Weight loss does improve sleep apnea.
Okay.
Often the response is about 50% or less.
Okay.
The cure where somebody really gets to a normal sleep study is in the 10 to 20% range.
Oh, okay.
And there has to be substantial amount of weight loss for that to happen.
Okay.
So commonly you would read in the media or in the textbook also is that you need 10% weight loss to have an impact on sleep apnea, to have a slight decrease in sleep apnea.
Okay.
And that would be about 20-25% improvement in sleep apnea.
Okay.
So that's what that 10% is. 10% is not to cure your sleep apnea.
Yep. It's just a decrease with the sleep apnea that you're...
So what we've learned with all these bariatric surgery patients who tend to lose 100 pounds and 150 pounds, and God, less than a quarter are cured of their sleep apnea.
Really? That's surprising, huh?
But maybe many others are reduced severity of sleep apnea. Ideally, to maintain good health, they should stay on their treatment.
Huh.
But many people stop.
Right.
Because at least there is partial improvement. They feel less tired. Psychologically, they feel better because they've lost weight.
Right.
That itself reduces their tiredness.
Right.
So often they, and then we all know what happens. You lose weight, you bottom out, and then you back up sort of halfway between.
Yes. Yeah.
So truly, when you've lost weight, maybe you were better enough, but then when you regain the weight, so patients will stop the CPAP because I lost weight, so I'm cured.
Right. But not really.
Not always cured, but at least they were improved. Right. But then they regain the weight and they fail to kind of realize that, okay, I should have been back on the treatment.
It's funny that 10%, we've heard that before when we talked about diabetes and reducing not reducing the risk, but controlling diabetes, how losing 10% of your body mass is important. That 10% seems to be important for a number of conditions. It's interesting. Yeah.
Yes.
So when someone finds the right mask for themselves and goes home, like how many people actually stay compliant with the machines? Like, do you get a lot of complaints back with the machines saying like it's difficult to sleep with them? Or are you just finding that people, it's like, oh my God, it's the first great night of sleep I've had in years?
I see the whole spectrum.
Mm-hmm.
So I do see the patients who would say, I'm a new man, or this is a new life and this is so great. Those are the ones who create unreasonable expectations for all others who are more in the average, and they're not going to have those. So, and there are then at the other end who just cannot handle it.
Yeah.
But majority of patients, this is just not a convenient treatment. What is sleep having a mask on the face? You can call it convenient. So anybody, if anybody misunderstood me to say this is the most effective treatment, I didn't mean to say that this is very convenient.
Right.
But either is death.
It is, yeah. but are you comfortable getting a heart attack and a stroke or early Alzheimer's or any number of other complaints?
Sure.
Right.
So we all have these trade-offs. So it is an inconvenient treatment, and a lot of discomforts are to be expected.
Okay.
And support is needed to work through those discomforts. Partly it's motivation from the patient, but partly it's the support from the provider. If somebody's complaining of discomfort and they have nowhere to go to, what are they going to do? They're going to give up.
Right.
Dr. Gupta, with your practice and the people that you see, do more people go on the little mask or that big one?
It's
kind of evenly distributed.
So to go back to your previous question, how many patients stay compliant?
Yeah.
The national average is 50%. Again, we can use the definition of compliance, and we're a insurance-run country, kind of.
Right.
So what has been created? Who is compliant? Medicare has created this definition of if somebody uses the CPAP 4 hours a night, 70% of the nights, then they're compliant. So there's that cutoff. Below that is non-compliant.
Okay.
And the way it is getting enforced, patients are being asked to return the machine if they've not met that threshold. Now they have to meet that threshold only for 3 months. After that, if they stop using, they're still called compliant.
Yeah.
So these are all kind of the fallacies of our...
Yes.
And then that trickles into the scientific data. So how many patients stay compliant? Well, there's a number that at 3 months, this many patients may be using it. This is hot off the press. This is last month.
Those are some amazing statistics.
So what that statistic shows is it's too small there. But what we're seeing is this the hospitalization rate?
Well, it says hospitalizations decreased by 5 to 10%.
That's the general, but
in 5 by 7.
Yeah. This graph is for the hospital admissions. This graph is for the emergency room visits.
Okay.
And at the bottom is how many hours of usage with CPAP.
Okay.
Oh, okay.
0 hours, basically that person is not on treatment or not using it. And going up to 9 hours plus.
Okay.
Why does it go up as people use it more? That's interesting to me. It's like a J curve, basically.
Yes, and that J curve is seen for so many things, but anybody requiring 9 hours of sleep or more often have other illnesses.
Okay, all right, that makes sense then.
So, but that is still below the baseline, right?
Right.
So even those patients with illnesses have a benefit of using the CPAP longer. But the most important point this study makes is that you see benefits even when the usage is as low as 1 to 2 hours a night.
Right, and it's significant.
So there is no cutoff, and to call these patients non-compliant and ask them to return the machine is
not doing anyone any favors.
Not doing anyone.
I mean, that's fascinating. It reduces hospitalizations by 5 to 10% per hour of usage.
Per hour of usage.
So if you use it for 8 hours, you've reduced your hospitalizations by 40 to 80%.
There is I don't know if that would translate exactly, but you can see the drop in hospitalization. How to read those numbers? There is almost a 50% drop in the hospitalization.
That's remarkable.
So with this kind of data, when someone's hospitalized, are they picking up on this and identifying, hey, this an underlying cause here of these conditions is like sleep apnea? Mm-hmm. Like how often is it caught?
It's a growing awareness.
Yeah. Okay.
Hospital is where the patient is least receptive to this. They're more focused on the current.
Of course.
Plus, obviously, you cannot really do a sleep study on a sick patient. It doesn't make sense.
Makes sense as well.
So really, we don't... but more patients could be identified in the hospital. Sorry.
I was going to say, I've had a lot of patients, many I've sent to you, that they were having, for example, a colonoscopy. And then during the time that they were given sedation, they had periods of apnea, so we sent them along. Or they're in the hospital and maybe they live alone, and now someone's observing them sleeping, and nurse notices that they have apnea, and they end up getting a sleep study. But you're right, it's always done as an outpatient, of course. It's not going to be done during the hospitalization.
But that's an interesting one, anesthesia. Bringing out the sleep apnea, right? That's a not only a time to identify, but also risk management.
Right.
So post-operative complications is one of the consequences of sleep apnea.
That makes sense.
Patients always have complications, right? We have different names for them. Infections, post-operative heart attack, post-operative stroke, post-operative atrial fibrillation,
right.
Post-operative delirium. We have post-operative hypertensive emergency. We have different names for all of the phenomena we observe. But if I showed you what happens to the blood pressure with every episode of sleep apnea, so that's blood pressure is not routinely monitored on any of the sleep study. This is kind of a research study where there is a catheter in one of the arteries, and you measure the blood pressure with every beat, and you can see that there are these normal breaths, and then the breathing has stopped or reduced in size, and then the breathing resumes here. And the blood pressure has shot up to 200, then it comes down, then it shoots back up to 200, Now, supposing this patient has severe sleep apnea, so they stop breathing 100 times an hour. Do see those patients, they're not rare. That's what would be happening to their blood pressure that many times. Now, especially in the post-operative setting, that they get monitored more frequently. Blood pressure is high, doctor. What can we do? Give them this blood pressure medicine, right? Root cause is sleep apnea.
And this is why these patients have heart attacks
Now,
and
then they get
cardiac issues. I mean, adrenaline response hypoxic, they have low oxygen levels, their blood pressure's up.
Now, imagine this patient is also complaining of pain because they had their hip replaced.
Right.
And they get a shot of morphine, or they get a the continuous infusion. And what does morphine do to sleep apnea?
Makes it worse.
Supposed to
Sure.
So that patient stops breathing, codes, gets intubated, goes to ICU. And root cause is sleep apnea.
Dr. Gupta, is like the spikes in blood pressure, is that only like picked up at these times? Like if they go to see Dr. Junkus during the day and you take your blood pressure, it's not going to be higher, is it?
It can be if they have uncontrolled or untreated sleep apnea. We think about that all the time with hypertension.
Okay.
Yeah.
So hypertension is one of the most strongly or most proven consequences of sleep apnea.
Okay.
And it's because of this, that all night when the blood pressure keeps spiking, ultimately it will stay up in the daytime also.
Yeah.
But when you look at normal progression of blood pressure from completely normal day and nighttime blood pressure, then the person develops sleep apnea. Their daytime blood pressure may be normal, the nighttime blood pressure may be abnormal. They don't get identified. They get identified as hypertension only when the daytime blood pressure is high.
Right.
So it is a little late by the time we have diagnosed them with hypertension.
I mean, by the time they have hypertension during the daytime hours from untreated sleep apnea, they've already had some end organ damage and whatnot, I would think. And that's why they have persistent hypertension.
Yes, there is some what we call vascular remodeling.
Right.
And
This is a little scary when it goes untreated.
Yeah,
like
it's a serious condition there,
God. So you just think of all the people
that's what's important for people to understand is that it goes beyond just annoying snoring,
right?
Or just a little bit tiredness. And
I mean, you're really doing a job on your body.
I can just take a couple of extra cups of coffee and I'll be fine.
Yeah,
right.
It goes much beyond that.
Mm-hmm.
So how's the average guy out in the community knowing about sleep? I guess through us, right? But like otherwise, like like I said it at the beginning, it's difficult to self-diagnose yourself, especially if you live alone.
Well, hopefully their primary care doctors have a good knowledge of it, but they have to ask the questions. If they have hypertension, they have to think about it. If they come in and they complain of snoring, they have to think, so we have to ask the right questions and then send them along to the experts like Dr. Gupta.
Is there an age sensitivity to this?
So middle age is when everything
starts falling
Everything
apart.
goes to pot.
It's okay.
Yeah.
So for example, for females, it's the menopause.
Why is he looking at me now? Okay.
You are older.
All right. 9 months.
So menopause is kind of the transition for a lot of things for female, and sleep apnea is no exception. So the percentage of females having sleep apnea skyrockets after menopause. But middle age is around that time when weight gain has happened.
Right. A lot of things.
Yeah. Typically, and that muscles have weakened a little. They're not the same muscles as you were when you were 20 years old. So
this is getting depressing.
I know. I think I'm going to take my headphones off. I don't listen to anymore. I guess, so as you're talking through all this, again, super important to have these conversations with your doctor, but suppose someone just saw the doctor and, can they just go directly to you? Are we calling and going through you? Like, can people book themselves into
it really depends on their insurance. I mean, you could go directly to a specialist if your insurance didn't require a referral, but, you probably don't get a lot of that, I'm guessing. It's probably mostly referred, right?
Mostly referred, but there are a fair number. It's not I would say it's closer to 10% that come directly to me.
Yeah, of course. After listening to this podcast, everyone's going to be calling up. Book me.
But we have a medical healthcare system sort of structured in a certain way where even if your insurance allows it, it would be nice to go through the primary care.
Of course. Yeah.
So they keep all the dots connected and not fragmented care.
Dr. Gupta, when you were showing the anatomical slides before, it doesn't make a difference if you're a back sleeper or a side sleeper? Like
it does. Let me see if one of these. So I'll show you a couple of examples of sleep apnea. So this is what a recording from a home sleep study would look like. And this panel is the summary of the whole night. And that black is oxygen level or oxygen saturation. It should be a fairly straight line all night long.
Looks pretty good.
And the number should be about 90%. So that is the 90 level. And we're in the mid 90s there.
Okay.
And then this is a 4-minute snapshot, and we can really, that's where the cursor is right now. So that's the 4-minute snapshot there. So the top green lines those are the snoring.
Okay.
And what we're really picking up in this equipment we use is the vibration in the airflow.
Okay.
This is not the decibel, but there are other equipment that would actually measure the decibel. And then the oxygen saturation is 96% and staying steady.
Yeah,
that's what normal should be. And those are the breaths. Breathe in, breathe out, breathe in, breathe out, and it should stay steady breathing. That's the chest movement, and that's the pulse.
Okay.
And the pulse has some normal variation, the size of the pulse with the breathing, but mostly it's steady.
Okay.
So that's what normal should look like. And this is somebody with bad sleep apnea.
Okay.
So now what you see is the breathing, the oxygen level, and that there's body position there. So S means supine, you're on your back, and you can see how much bigger drop in oxygen level is on the back, and the short time there on the side, the drop in oxygen level was less.
Yep.
Okay.
So the sleep apnea is still there, just less
pronounced. Yeah.
Some patients will have sleep apnea only on their back, and not on their side. Now, when you look at the 4-minute snapshot here, you can see the breathing stopped, few breaths, 3-4 breaths, then stopped. To get a idea of the time frame, this is 30 seconds between these two lines here.
30 seconds.
30 seconds. And you can see the oxygen levels drop with the pause in breathing. Then there's always about a 10 to 15 second delay.
When do you wake somebody up?
We don't. Even if the oxygen level goes down to 40%, we're not going there and waking up the patient. They're doing this every night at their home.
Okay.
We get the test recorded.
Yeah.
We don't get scared with 40% saturation. When I'm in ICU, I would be very scared.
Okay.
Yeah.
Not when I'm in sleep lab.
Okay.
Yeah. So that and you can see the impact of this on the pulse.
Oh yeah.
All right.
So that tells you what the heart is going through. And that stress on the heart, or the heart is kind of running a marathon.
Right.
And that damage just adds up slowly night after night after night.
Dr. Gupta, you know how we had gone over the symptoms, like how you feel? The body does such a good job at compensating. Do people like compensate for this, or feel like they are fine when actually they're not?
Yes, there are. So these things happen in pretty much all diseases that we talk of. That when we talk of the average symptoms, snoring and tiredness, not every person. And there are patients I see with very severe sleep apnea who say, I'm not tired. And they're not lying. They're not making it up. They're actually not tired.
They've adapted to some extent, but it still has the deleterious effects on their system.
So that debate needs to be settled with some science.
Mm-hmm.
And we don't have such large numbers of patients who have severe sleep apnea and don't feel tired, or they've not kind of collected those patients and tried to analyze their outcomes to say. So right now, which patient with sleep apnea will have bad outcome is not a perfect science.
Okay.
But there's a general consensus that those who are too tired, meaning that sleep apnea is having a significant impact on their one organ, at least brain, which means it must be. So sleepiness is kind of a tip off that this person is at risk of severe damage. More drop in oxygen level, that is risk of more damage. So those are the patients who would be pushed towards more treatment.
And when you're looking at like family histories, like someone who has a history of cardiac disease, like if their dad died from cardiac disease when they were 65 and he had dementia and everything else, like these are some things maybe you should be a little more concerned about your sleep hygiene, right?
That sleep hygiene is very different from sleep apnea treatment. Sleep hygiene does nothing to treat sleep apnea.
Okay.
Similar to dental hygiene or something. It's a basic requirement for everybody to have a regular sleep schedule, to have adequate amount of hours available to rest.
Yeah.
So that will have its own impact. But you can have a regular sleep schedule, sleep for 8 hours, and still not get restful sleep. So the quality of sleep that is being affected by sleep apnea requires treatment of sleep apnea.
Okay.
This has such far-reaching effects. It's amazing.
It's insidious.
Think about it. It's hypertension, MI, so cardiovascular disease, dementia, so brain-related issues, ability to be alert during the day, which I'm sure translates to motor vehicle accidents and issues like that if someone's not aware of what's going on. Really amazing.
As a general rule, motor vehicle accidents are 5 times more common in sleep apnea patients.
Right.
And patients in what we call mission critical jobs or safety related jobs, commercial driver license, DOT medical exams,
of course,
they require treatment of sleep apnea as a condition to certify.
Right.
Oh.
There have been several high profile accidents that are linked to fatigue. Some major train accidents, nuclear power plant accidents that are related to fatigue. So there's serious damage that can happen from.
Sure. It's really remarkable.
All right. So now from listening to this podcast, I know I have a certain amount of symptoms. I'm kind of clued into, oh boy, I better go get this checked out because this is all the stuff that can happen to me. And this is the stuff that does happen to me if I have sleep apnea, and then I may get hooked up with one of these machines. Is there anything else? Like there must be a lot of research in this area now that it seems to be growing, right? So what's up next past these?
What's the future, you mean, of treatment?
Thank you. I was struggling with that question. What's the future of sleep apnea?
Sleep apnea treatment? Will it remain this CPAP machines and masks, or will it be something else?
For the foreseeable future, we're looking at improvement in the CPAP treatment. When we say CPAP, let's call it PAP treatment, some form of positive airway pressure. There's CPAP, there's BiPAP. But I think for the foreseeable future, this will remain the mainstay of the treatment.
Okay.
And if you look at any other options, you would see that who is it appropriate for? The first category would be appropriate for patients who are struggling with CPAP or cannot tolerate CPAP.
Okay.
Now, when it comes to mild sleep apnea, you have more options. So for mild sleep apnea, you don't really have to be going for this CPAP first because that can often be controlled by a mouthpiece, like a dentist appointment.
Okay. That makes sense.
So that can be an alternative treatment as a first choice.
Yeah.
Although, if you ask me, the amount we are in infancy in sleep medicine. we don't even know how to measure sleep apnea properly. So it sounds like we are very scientific here, but this is not that scientific.
Right.
That counting pauses in breathing, if your pause in breathing is 1 minute long compared to somebody else whose pauses are 15-second long, your number will be 4 times less. So the person with shorter pauses will come out with a much higher AHI and sound like severe sleep apnea. The person with much longer pauses and bigger drops in oxygen level, to me, that's as bad sleep apnea or worse sleep apnea, but comes out with a smaller number.
Yeah, I mean, that seems more concerning.
So that's just math. So the way we have this counting in AHI as the main,
Most accurate.
that's the best we have right now.
Yeah.
But we do need to find out more ways of measuring the quality of sleep. We should be really focusing on the impact of that sleep apnea on the body rather than the number on the sleep study.
Yes.
Okay.
Yes, totally.
So that's how I tell my patients. I'm not treating the number. I'm treating the patient. And I try to convince them that there is impact on your body, so you should be treated. Doesn't matter if the sleep study report says mild sleep apnea.
It's a great way to look at it. As we draw to a close, because unfortunately this time really flew by. We could talk for another hour about this, and maybe we'll have you back at some point to talk more, because I think we just scratched the surface.
There is a lot more to talk about each aspect of this. There's so much that.
Oh yeah, I think we just scratched the surface here. But is there a message that you'd like to leave our audience, and is there one great patient story that you'd like to leave us with?
So let me just pull up a patient story first. And this is nothing but my office note.
Okay.
And what is highlighted in red, this is a real patient I saw last week. And basically what we're seeing is when I come to the diagnosis, and I think Nancy raised this point earlier, I rarely see a patient who has only one thing affecting their sleep.
Okay.
In real life, the patient has sleep apnea, they have shift work, they're sleep deprived. I only get 5 hours of sleep, work 7 days a week because he works 2 jobs. So then the complaints he has, how much tired he is, how much sleep he is not just from sleep apnea, then it's from multiple problems, night shifts, lack of sleep. Maybe there is another disorder going on like back pain that's disturbing sleep. So typically we see these mixed pictures, and then we treat their sleep apnea. And because the sleep apnea is one of the biggest contributors in this whole equation here, at least for this patient, had very severe sleep apnea. And then we look at his CPAP usage and is loving it.
That's great.
So that's kind of the average patient rather than a.
Yeah.
Okay.
Yeah. So this is what we see day in and out, that sleep apnea is part of their whole sleep problem.
I mean, this patient really benefited, and I see this a lot too. We always think, oh, these things are hard to wear and that, but I have patients who come in and say, this is the best thing I ever did.
I was just feeling them though. They're very soft.
They
I know they're cumbersome, but it doesn't seem like it. Feel like that.
No, it's
like soft.
That doesn't seem as.
Like I remember them to be like harder. We used to have patients that came into the hospital and used to have their own machines. They'd bring them in. Yeah. I mean, this is going back 20 years,
advances,
but these look a lot better than those.
So that's exactly what I want the patients to take home from our audience.
That's a good segue. We kind of set you up for this one. Yeah.
CPAP is not as bad as you think. It's bad mentally, psychologically. Once you cross that barrier, it is really not as bad.
Yeah.
Especially if you're going to feel so much better.
But the other thing, the take-home message should be the awareness that sleep apnea is actually very common. And we didn't have time for some of the other things. But if you look at prevalence of sleep apnea, about 15% on an average. Diabetes is about 10%. Asthma is about 8%. So when you look at how many patients have sleep apnea, that's a lot more than most of the other disorders we think everybody has it.
Right.
So it's very common, and majority of those patients remain undiagnosed. But it is a serious condition that is leading to hypertension, leading to development of diabetes, taking them from pre-diabetes, pushing them towards diabetes. So all of those serious concerns, first step is being aware, and that if we just say sleep apnea causes snoring or sleep apnea causes sleepiness, and we stop there, then it's not a serious problem.
Right.
We say sleep apnea causes heart attack, sleep apnea causes dementia, sleep apnea. It's the same way diabetes is asymptomatic. Should be nothing. But when you say diabetes causes renal failure, kidney failure, and gets you to dialysis, then diabetes becomes a serious illness.
Yeah.
When you say diabetes causes heart attack, then it becomes a serious illness.
Right.
Otherwise, if you just say diabetes causes high sugar, who cares?
That's a great point.
So how we connect the disease to the outcome, and that has not yet happened in the narrative. The narrative
I think
is
a lot of people don't understand that, and that's a key point.
Yeah. So that's kind of what I would say is.
That's great.
And with the home sleep studies, the access to testing has become easier, simpler. One of the barriers was I don't want to go sleep in that sleep lab with all the wires on me.
Right.
So that barrier has been brought down. So the testing is more easily available. And the treatments have become, and this is like a Cadillac compared to the machine I had to use 20 years ago for treating my patients.
Sure.
Yeah.
So we've come a long way.
Well, hopefully this will really help to get the word out to a lot of patients. This was a great conversation, but the most important question is how do people contact you if they are concerned that they have sleep apnea and they want to have an evaluation?
I think Google finds me more easily.
we can put your phone number in.
It'll be in the notes.
We'll put it in the
show notes.
Dr. Gupta, sleep specialist in Somerset. It's right there.
There it is. Okay, very good, very good.
The phone number, I don't think I have a slide for that one.
Well, we can post.
We'll post it.
We'll post it. Okay, great. All right. Well, very good. Well, thank you. Anything else, Nancy?
No, thank you so much. Great. You scared me to death. Thank you.
Nancy will be calling you next week.
No, right?
Or tomorrow, probably. But thank you so much for this. This was really great. I learned a lot. I'm sure that our audience did too. And I want to thank all of our audience for listening to the show. And if you'd like to become a sponsor, contact us at 774-319-4230. And special thanks to Ron Gamache for our intro music and the BioSkills of Northeast for producing our show. And Bay Coast Bank, of course, our sponsor, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Thanks again, everyone. And we'll catch you in the future very soon for another podcast. This is the 27th Degree with Chris and Nancy.